Good afternoon again. We're really pleased to welcome you to the Foundation for Opioid Response Efforts weekly webinar series focused on how we maintain and support access to opioid use disorder treatment during the COVID pandemic. Particularly excited about today's webinar topic, which is a focus on how we create effective telehealth patient experiences as we rapidly move to remote and telehealth technology to be able to maintain access to treatment. We're hearing a lot of problems with them. If you give us one moment. Just test the sound again. Just testing the sound. Is that better?
Sorry, Karen, it's still cracking up a little
No?
bit.
Okay, I think it might be the storm. Okay, Ken, if you can hear better, do you want to pick up for right now?
Sounds better now. So
It's better?
Yep.
It's better. Okay, all right, thanks. Okay, let's go. Let's keep going and see. Ken, we can go ahead with advance the slides. Just quickly into this slide. Our agenda today, we'll just go over a little bit quickly of the logistics.
Sorry, Karen, the sound is going back and forth, so I can go over if the sound is better. Great. Hi, everyone. This is Ken.
Apologies.
Yeah, I'm the Senior Program Officer for the Foundation for Opioid Response Efforts. Please let me know if the sound is going in and out. So first, I just wanted to go over quickly the agenda for today. We'll start off quickly with a welcome and webinar logistics and if you are part of our webinars beforehand, you'll know much of this already. And we have a great panel and a great program for you today. It's going to focus on the patient perspective in developing your telehealth programs during the COVID-19 response. So first off, some webinar logistics. One, the webinar will be recorded and will be available on our website, forefdn.org, shortly after the session ends. The slides will also be made available for download on our website, so don't worry about taking any notes if anything is just printed on there. We will have a question and answer session at the end of the webinar. To submit a question, please use the Q&A box found at the bottom of the Zoom screen. You could submit the question there, and you could also see questions that have been submitted by other people already. What you can do is upvote those questions that match the question that you want to ask, so that we can make sure that we're responding to the most pressing questions first. A question and answer document will be also available at the end of the session for the questions that we cannot get to. Any resources that you would like to share with everyone else related to this topic or for any issue with the COVID-19 response, please email us at info@forefdn.org. And finally, there will be a brief survey at the end as we develop more webinars and more programming. We want to make sure that we're covering topics that are important to you. So please submit that complete that brief survey at the end of the webinar to provide us with any feedback that you have. So just quickly, we just want to again describe FORE's response to the COVID-19 national emergency. We're continuously looking for ways to provide broad assistance during this time. You can look at our website daily for up-to-date resources and guidance by the federal agencies and from us as well that can help you as you develop your programs during this this extraordinary time. We, as many of you know, we are doing these webinars as a weekly series every Thursday at 3 p.m. Eastern. We will be taking a pause next week after doing 4 of these to evaluate one-year surveys and see, which, we have some good topics lined up, but want to make sure that we are developing those webinars for, on issues that are important right now. And as always, we can help always facilitate connections with experts in tech and provide, connections to technical assistance where we can. So please reach out to us whenever, and also submit any ideas that you have that we may be able to develop as well, and continue to go on our website. So we have a fantastic lineup of presenters today. And we will start with Dr. Tanya Lord, who is the Director of Patient and Family Engagement at the Foundation for Healthy Communities, who are one of our new grantees in our first 19 inaugural grantees on access to treatment. With that, I will hand it off to Tanya.
Great, thank you, Ken. We can go to the next slide. So just as a quick introduction, my role in New Hampshire is I'm the Director of Patient Family Engagement for the sister organization for the Hospital Association. And I do work with all of our healthcare systems across the continuum of healthcare in bringing the lived experience, so really the experience of the frontline staff and primarily patients and their families, in designing, implementing, and evaluating healthcare. And typically I do this by bringing groups together and doing different activities and brainstorming and design work with groups. Obviously that's not happening right now, but being a rural state, we've often had trouble in our patients with a substance use disorder diagnosis accessing treatment. So especially far up north, it's quite rural. And I realized when I put this slide up that it has our state motto, live free or die, but we're actually doing pretty good at staying home and following the guidelines. So as independent as we are as a state, we are doing pretty well in this pandemic of taking care of ourselves and everybody in the state. So we can go to the next slide. One of the things is we think about bringing on patients and families onto telehealth is really thinking about the terminology that we used. I can say that we've all become very comfortable in healthcare in different areas using the term telehealth, but when I talk to patients about that term, they really are confused as to what that means. Is it a phone call? Is it a virtual online? So really thinking about using the actual term, if it's a virtual visit or using virtual appointment. I have online, I don't have telephone on there, but if it's a telephone appointment, a telephone visit, but really thinking through and remembering that our patients don't necessarily know or become as familiar with the terminology that is really familiar to us. Next slide, please. So there are several pros and cons to virtual care. And most of these are pretty straightforward. The idea that it's more accessible and more comfortable. We're hearing from patients that being in their own home where they're more at ease. So none of that white coat syndrome or having to go into a clinic and not sure exactly what the process is, but being at home makes it easier. Patients feel more comfortable to be open and talk about their situation. And there's the potential also to include patient to family and caregivers. Now that could also be a con. It could be in the other side of this list, but the idea that patients or that family members or caregivers can then be part of it, hear some of what is being said where they may not be normally able to go to appointment, but now with so many people staying home, they may be available in that way. Technology problems, we just heard Karen's voice break up. They're unavoidable and they're going to happen. So you definitely want to ask the patient for forgiveness and patience in doing it. There's a huge variety of how patients are familiar with technology, and it can be really easy to make people feel like they are supposed to know something that they don't know. I have kids in their 20s, and I feel that way a lot, and they make me feel that way a lot. So really thinking about how can we do this in a way that doesn't make people feel like, hey, you're supposed to already know how Zoom works or how where your camera is on your phone. And then we risk lacking personal touch. Now, there's lots of ways to overcome that, but just acknowledging that up front, that this isn't the same as meeting in person, and how we can make it more comfortable. And then especially in rural areas like northern New Hampshire and other rural areas, the network may not be available. And even in cities with so many people at home, networks are being overloaded, so the internet may not work as easily as it used to. So really being aware of that and having some backup. And then clearly there's privacy concerns. A patient can use headphones so that other people in the house are not hearing what the provider or other side is talking about, but there is clearly privacy concerns if a patient can't be on their own. Next slide, please. So as we think about going, and I know people have had to do this really fast and get prepared, but even if you've done a few appointments or done many appointments online or in a virtual space, is think about who can you actually practice with. And if you have a hospital that has patient family advisors right now, they're not meeting and they're not doing a lot of work. And these are volunteers who can give you the perspective from a patient, or even somebody in your office who's non-clinical, who hasn't had the experience of doing a telehealth appointment, can do that. One of the things, if you've done any kind of Zoom meetings, is the idea of making sure you know how to make eye contact, to look in whether you're looking in the camera or you're looking in a different area, and that's something that can be practiced. And then really asking, how does it feel? So I know that I've done a lot of eye contact conversations with providers, and you don't want to be staring, just like you wouldn't stare directly into people's eyes the whole time. You don't want to be staring the entire time directly into the camera or directly into their eyes, but thinking about how does it feel? How am I coming across? And then what can I do to make it more comfortable? And meaning literally, how are you interacting with the camera, or how are you speaking on the phone? And how is it coming across? So practicing with a patient family advisor or other patient representative. Next slide, please. And remembering that people are going to have, you're going to have an introductory phone call and confirm who will be participating in the appointment, so there aren't any surprises if there's other people involved. But really thinking about asking in that introductory phone call, how do you prefer to learn new information? And going through, is it through audio, hearing it, reading it, etc. And thinking, how are you going to provide that information, whether that's video, a phone call, print material, parts on your website, or if you can actually get somebody to do a practice session with the patient so that they really do understand how it's going to work, if they're a more hands-on learner. Next slide, please. So again, including all of these different things, I won't go through each one of them, but thinking about what kind of language needs are you using English only? Are you able to bring on interpreters? And also identifying any kind of visual or hearing concerns. So again, practicing with the patient or having a practice session is something that is helpful with them. Many of the online virtual vendors have video tutorials for patients that can be made accessible to them, or you can make your own. And I would encourage it, if you're going to put together education material, again, see if there's not a patient who can review that and help you with that. And then as you develop this going forward is you're going to start hearing the same questions and asking, creating a frequently asked question document is also helpful for patients. Next slide, please. So obviously, after introductions and stuff, I think it's important to just assess their comfort level with the technology and with the space where they are, and if they're feeling that this is a comfortable and still an okay time to discuss what needs to be discussed. And if there is a camera, creating and engaging in that virtual space, like I talked a lot about the eye contact, but also describing what you're doing. So if you're in person and you turn away momentarily to type in notes or to write notes, the patient can see you, but in a virtual environment, they may not be able to tell why you've turned away. And so just explaining very briefly, I'm just writing some notes here, let me document this, and why you're turning away from the camera is important. I've been on several virtual platforms, and when I look away, people will catch me and ask, you know, why, what are you looking at? Or why did you, or it appears as if I'm not interested, even if something has just caught my eye. So really thinking, explaining why you're turning away from the camera, and really thinking about where that camera is situated versus what you're looking at, so you are not turning sideways to the camera. Next slide, please. So after the appointment, because this is so new for us, or for many of us, is asking the patient for direct feedback, if that feels comfortable, to say, to get the feedback so that we can continually learn how to improve this, and then debriefing with staff so that everybody can understand, is the platform working? How did it feel? How are others dealing with situations that may have come up? And then just continually be willing to improve and try something different. Next slide, please. So the truth is, we're not going to be able to put this genie back in the box. We don't know how regulations will go back to, we don't know how or what the regulations will be after the COVID crisis is over or dwindles a little bit. And I'm not sure that we're necessarily going to want to put them back, put that genie back in the bottle. And I know the patients aren't. So I think some will like this better. And I'll just share a quick story about my son, who does have a substance use disorder and is currently not in any kind of treatment. He's been in and out of residential rehab and other types of treatment. And he is, at this point, really resistant to treatment and is terrified. He has had some experiences being brought to the emergency department against his will. But he's also just, he has a real deep fear of going into a clinical environment to receive treatment, because he has a belief that somehow he will end up back in a residential setting against his will. And with all of the COVID-19 stuff happening and realizing how much care is happening online, I've approached him with that. And for the first time in many, many months, probably in a year, he's been interested in potentially initiating treatment if it can happen while he's at his house and safe and doesn't have that overriding distrust or fear. So I think it's important as we go forward to think about how can we make this more comfortable for patients as a whole, and then also just the idea that it's a better way, it may be a better way for some people to receive care. So thank you. And with that, I'm going to turn it over to Dr. Carter.
Hi, I'm Dr. Josh Carter. I'm a clinical psychologist with Cabot Creek Health Systems, and I'm the director of our MAT and addiction treatment. If you wouldn't mind going to the first slide. So the main thing we did right off the bat, because we needed time to figure out how to do telehealth, and if anybody's still trying to figure that out, what we did right off the bat was we extended Suboxone scripts for patients who were stable. So anybody who was on, at the moment, like every 3 days to daily, doing well, we put them up to weekly, weekly went into bi-weekly, bi-weekly, monthly, monthly to bi-monthly, just to give us time to figure out how to do telehealth, but also to space out the groups. So we would have smaller groups less often. That way we would, be able to comply with the group size, policies being put out. But then that would also let the patients still get treatment, still get their medications, and give us time to educate them during groups on what telehealth was going to look like as we figured it out. And then during that time, we would be able to consent patients and basically figure out how to help them figure out how to operate the systems as we were still having them come in. If you wouldn't mind going to the next one. So some of the big changes we made to treatment as we were working on telehealth was we usually have a 12-step meeting requirement. If patients are required to do 4 12-step meetings a week throughout their first year in treatment. We discontinued those as a lot of the 12-step meetings have been discontinued in the community. And it was unfair to have that requirement if meetings aren't going on, and also to expect patients to go out and do that with everything with COVID-19 happening. We are encouraging the online meetings, but where we're in West Virginia, we are also very rural, and there's just not a lot of infrastructure for internet, so patients have a hard time getting into those meetings. The ones we mainly use are In the Rooms is a really good one. It's almost like a social network for recovery, but then also there's regularly scheduled meetings. And then we've been Celebrate Recovery, we've had some luck with too. The other thing we have done is reducing the number of random drug screens. So just so we reduced the number of times patients have to go out. We mainly reduced it to the bare minimum of what we require. So once a month if they're in phase 1 or weekly, every 2 months for bi-weekly patients in phase 2, and then every 3 months for phase 3, which is our patients with over a year. What that has helped us do is reduce contact. We can still call them in if we need to. So say there's like alcohol, fear of alcohol use or benzos, we can call them in on a need-in basis, but it's very minimal. All right, if you wouldn't mind going to the next one. Some of the other changes in our state at West Virginia, they suspended the behavioral health requirements until May 1st. So that typically meant patients had to have an hour of behavioral health per month. So we took that, it gave us a little bit of a leeway to where we didn't have any behavioral health for the first month to help me figure out how we're going to do all this, or for the first week. After that, we have started doing shorter, more frequent phone appointments. So anywhere from 15 to 30-minute appointments once a week to every other week. And if a patient needs more, we've been doing phone check-ins, just a brief 10-minute talk. How are you doing? How's your medication? Relapses, how are you dealing with boredom? Anything like that. One thing as a program we do is we count our Suboxone wrappers just as a diversion prevention. We've discontinued all of that, just patients don't have to bring them in, and then our care managers don't have to be constantly touching potentially contaminated surfaces. And then every time a patient enters the building, we've started a number of, we take their temperature, O2 stats, look at any potential symptoms, and we provide them with a mask and any type of hand sanitizing, hand washing they might need. We haven't had to do that too much since we've started telehealth over the last week. We've had 2 patients actually in the building. Other than that, we've seen about 86 people by the end of the week via telehealth. So it's helped a ton. If you wouldn't mind going over to the next one. So some of the considerations to take into account, so basically some of the things I wish I would have known right off the bat when I was figuring it out was, making sure we do informed consent of risks and benefits with every patient, especially with confidentiality. We've had to do extra consents as we go through the group telehealth, which is a big thing we work towards for the patient's benefit. And then offering options to the patients. So especially in West Virginia, not everybody's going to have access to the internet. So letting them know there's telephone services, but then also we can do it via webcam video if you'd like that also. Making patients aware of the limited infrastructure. So basically giving them the expectation that, hey, this may cut in and out at times. You may drop off the call. We may drop off the call. That's to be expected, just to minimize anxiety. And then looking at patient resources, what do the patients have that they can use for telehealth? Do they have the ability to use webcam? If not, then why would that be an expectation we would put on them? So basically, like we should do every day with patients, meet them where they're at, especially with telehealth and everything going on. Also making sure they're using secure connections, So, their private Wi-Fi or Wi-Fi with a password just to be safe. And then one of the things we did was we made specific telehealth appointment types for billing, just to make it easy for our billing office. So we have like telehealth MAT, group medical, telehealth MAT, group individual, or group behavioral health, and then the same thing for individual for behavioral health and medical. So just looking at those considerations as you go is a real good way to get things going. All right. So one of the main services we're offering right now is individual telehealth. So it started out with just phone. And at the moment this week, we have moved on to Zoom and using the video or voice with Zoom. So these are typically 30-minute appointments with the patients, weekly to bi-weekly. So they're scheduled as usual with the care managers, and the appointments are communicated with the patients. We're trying to make telehealth seem as similar to traditional treatment as possible, just to minimize confusion and to reduce barriers. Barriers is such a big thing with substance use treatment that we want to put as little as possible with this too. And then the behavioral health provider will coordinate the telehealth. So the behavioral health provider will schedule the Zoom meeting. And then we have specific emails. We didn't want to use our professional emails per admin's request. So we have specific emails made for each phase. So we have like a phase 1 email, phase 2, phase 3, and then emails for our different rural sites. And that way we can use those emails to communicate telehealth appointment information with patients. And then also we've used the Zoom for medical individual, and our medical providers actually got creative with it. We typically will do like witness dosing with fear of diversion. We had a really kind of worrisome event pop up with the patient right when all this happened. And we actually had him download Zoom on his phone, and he does witness dosing with our medical provider every morning, which helps a ton. All right, if you would move on for me, please. So the one thing I was really wanting to do was the group telehealth. Our patients have always pushed that the group appointments are what really keep them going, that connection with the other patients, just that whole group environment. So I really want to be able to get group telehealth to work. From the things I looked at, Zoom was the most viable option for us. One of the reasons that was we only had so many patients that could get on the internet and somebody with phone. With Zoom, they can do both. And then this is just a brief overview of how we're typically running that. So patients will check in with care managers for 30 minutes, then group medical for 60, and then group therapy for 60. And then after that, we send the patient scripts, either e-prescribing or phone, to our pharmacy, and we go from there. So it's minimizing changes. So it's going to be as close to normal as possible for the patients. Next slide, please. So the check-ins are run by our care managers and our medical assistants. And this is mainly, we get our information we normally would during a group visit, but then also some extras for telehealth. So typically the care managers will mute and unmute patients as we go, just for kind of order, and we don't want everybody talking over each other and it get too confusing. And then as patients check in, they can rename the patients, whether it's appropriate names. We had a patient sign in with a name that was not good for group, so we had them rename that. Or if they're calling in with the phone number, we can check in, see who that is, and then rename it so we know who we have on the call. Then we check days of sobriety, relapses, current issues, any needs, just like we would in a typical appointment. Then we've also added on, where are you? Is it private? We want to make sure their privacy is maintained and the other patients. What's a callback number in case we lose you? Closest emergency services in case something happens. And then we typically do a reminder of all the group confidentiality beforehand. Next slide. All right, the other thing we wanted to be able to do is keep taking on new patients. So right now with some of the policies and everything that have been pulled back, we can start new patients with either a two-way video conference call. It has to be able to see the provider and see the patient, or a time-limited face-to-face. So with the time limited, we're typically doing no more than 15 minutes, 3 feet apart, get the patient in and out. Otherwise, we can start them completely via telehealth. The problem is not every new patient's going to have those resources, especially a lot of our new patients are homeless and they're just not going to be able to do that. So real quick face-to-face, we either give them a consent packet here or mail them one if we did it via video call, and then they will complete the consent and their behavioral health intake over the telehealth, whether it's phone or video. And then what we do is we pull them into weekly groups at that point, and they'll just be sent the information to start doing telehealth groups. Next slide. So some tips for making it work, just some general information. More things I wish I would have known is, make sure you have regular communication. So I tend to send out, even with right now us doing telehealth, morning updates to staff. That way everybody is on the same page of what's going on. Where are we at in the process of telehealth? Where are we at in scheduling groups? And then that way they can communicate it to patients. And we also have our main site in Kanawha City, but we also have satellites in Sissonville and Dawes, West Virginia. So can't always go out there. So being able to send that to them too. And then transparency with staff and patients, letting them know what's going on and why, helping them navigate it, teach them, everything like that. We've made very clear directions for staff, so anybody can just jump right in and follow the directions. And we also have directions for logging into Zoom meetings that we have mailed out to all of our patients to help with that, how to log in, how to navigate. And then we send them the email every week with the login information. That way we're changing it up. The big thing that was the most helpful for us was doing a test run. So actually about a week ago, a Friday, 1 week ago before we started even doing telehealth, we had about 2 patients from every phase log into a Zoom meeting with us just to test run it, look for bugs, look for any type of barrier you might run into. And then that way we had 2 to 3 patients in each phase that the other patients could reach out to. So if they couldn't get a hold of us and they were having trouble getting into Zoom, they had contacts within their own therapy groups of people who already knew how to do this. And then, yeah, that's about everything I have. So I'll go ahead and pass it on to Dr. Weinstein and go from there.
All right. Thank you so much, Joshua and Tanya. You're tough acts to follow, and I hope I'm going to be able to offer some interesting contrasts and some similarities to what the other speakers touched upon. I am an academic family physician and a public health researcher with additional addiction medicine specialties. However, I'm very, very grateful that my clinical work and research work and advocacy work is based in 2 nonprofits that are ending homelessness for people with serious mental illness and substance use disorders in Philadelphia. So I'll explain the relationship between those 2 organizations shortly. But basically, to keep in mind, I'm coming from a urban, predominantly North Philly, although we get folks from all over, situation. We're based through an FQHC program with multiple satellites in non-traditional settings. And many of our patients, very high numbers of our patients, are formerly homeless or unfortunately currently homeless, or fortunately newly housed. So there's a number of different challenges and successes in our program. Did I just advance the slide myself, Ken?
Nope, that was me.
Oh, okay, thanks. I pushed the down button too. Okay, thank you. So I'm just going to talk a little bit about the epidemiology of what we're seeing and the impact on our folks with opioid use disorder, and some bits about our experience on the ground here in Philadelphia and some of the creative solutions and workarounds we're continually coming up with as late as an hour ago. So next slide, please. Right, so again, I'm going to be talking about epidemiology and impact. I'll take the next slide, please. You know what, I'll go back. Okay, so race, I don't know, probably a lot of folks have seen the data that came out from the CDC yesterday that looked at patients hospitalized with COVID-19 in 14 states over the month of March. And in that catchment area, 14 states, 18% of the population is African American. However, 33% of the folks hospitalized were African American. Again, sort of suggesting that the same health disparity issues that are affecting folks all the time are again being amplified through the COVID pandemic. This is especially important for our population. We serve a relatively high number of African American folks in our medications for opioid use disorder program. We have about 57% are African American, and that's in strong contrast to the percentage of folks who are able to access medication for opioid use disorder treatment in Philadelphia. It's about 29%. So we've worked really hard to have increased access through a low threshold program that I'll talk a little bit more about. Also, again, as you know, and as the CDC report confirmed, about 90% of the folks who are hospitalized already have an underlying chronic condition, and that is the same as what we see for the folks we work with. A lot of COPD and lung-related disabilities, hypertension, cardiovascular disease, and just basic wear and tear. So in terms of impact on our population of people with opioid use disorder, they're at increased risk for severe illness because of their underlying medical conditions. They're at increased risk for overdose, both because of the social isolation. Here in Philadelphia, we really encourage people, if they are going to use, to not use alone. That's getting harder and harder. And then also, it's fortunate that we're letting people out of jails and prisons earlier, but that higher volume of folks being let out means that people are at higher risk for overdose in that very critical time as they're leaving prison and having withdrawn in the prison setting. On the flip side of the isolation, there's of course increased risk of transmission, both through overcrowding and trying to get access to any services, even waiting in line for food pantries, and also increased risk of transmission from shared equipment. And then the disruption in services really runs the gamut from challenges in accessing treatment to challenges to accessing safe injection supplies for people who are still working through things. And then we don't know at this point what impact this will have on the illegal drug market. So now I'll take the next slide. Thank you. As I mentioned, Project Home and Pathways to Housing are two different organizations working to end homelessness for people with opioid use disorder. Project Home has residential settings. They are also the city leader of our 24/7 street outreach program. And then our federally qualified health center has multiple satellites in the city. Pathways to Housing is one of those satellites. Pathways to Housing is a housing first organization. Been housing folks for about 10 years with serious mental illness. And in 2016, the city of Philadelphia asked Pathways to adapt their model to help with folks living on the streets with opioid use disorder. The whole world has seen pictures of folks living under the bridges in Kensington and things like that. So at this point, Pathways has housed, since 2016, over 200 people with opioid use disorder. And we've learned a lot from working with those folks. So we have a lot of collaboration, a lot of team-based care, and I will allude to that in my next slide. So these are challenges for people seeking treatment. And I think I also want to put out there that there's challenges for people who are still using that we just talked about. But people seeking treatment, for us, the lack of phone access and the phones being cut off, the support groups, Joshua, I really want to catch up with you after this and get some of the details of how you're doing your telehealth groups, because we're working on trying to do that through Facebook because it's accessible to people, but it sounds like you've already done all the work for the procedures. Folks suffer a bit from telehealth and a lack of in-depth assessment and sometimes missing that human connection. although we're going to continue to use the tips that we've learned and the tips that Tanya talked about to increase that. And then, as everyone is experiencing, again, the systemic and social stress can both exacerbate substance use and trigger it. Next slide, please. Some of the creative solutions we've come up with on the ground is rapid interdisciplinary contingency planning and constant workflow modifications. We basically have 2 one-hour meetings a day to talk about our populations and to run the list of them like you would if you were in the hospital, and then at least an hour of more procedural organizational meetings every day to respond to this. We have a dedicated primary care person each day designated to help problem solve MAT issues on the ground. People have a little bit more access to food since our own pantry has loosened the restraints. And then we're coming up with all kinds of workarounds of using a friend's phone or a neighbor's phone to do a telehealth visit. And then we have a lot of staff in the field and doing outreach, and that allows us to use FaceTime for visits. Next slide, please. The advantages of telehealth for us, especially in an FQHC, is that they are now reimbursable. It also allows us to rotate staff who are on site and who are remote to reduce staff exposure and risk. And in fact, the telehealth has really lends itself to improve population health management. So I want to just finish up with a few slides talking about that. So in the beginning, we did sort of a quick and dirty, simple population health management system. This is a spreadsheet on a computer with the patient's names and phone numbers. And then, for example, at Pathways, we have about 50 to 60 folks on buprenorphine and another 20 or so in a methadone program. We review every single person every single day and keep track of when they're due back, either for telehealth or in person. And then you can see all the workarounds we've come up with. Our nurse practitioner goes out in the field for wound care. We take feedback from the staff about who may need a different approach or a different dosing. We keep track of folks that we've tested for COVID, and on and on. But this is just a snapshot of every single day. And then the next slide, please. So at our main federally qualified health center with some younger providers, they've done a more sophisticated real-time spreadsheet on our SharePoint that everyone is accessing throughout the day. It has drop-down lists to make things easier, and it allows for pretty detailed comments so everybody knows what's going on in real time. And I'll just finish with the last couple slides here. We were really excited to be able to offer new intake appointments for medication for opioid use disorder. And thankfully, our operations manager came up with this protocol for us to adapt and revise. But we are doing both telephone, audio-visual telehealth, and in-person new patient protocols. And this is just briefly, I'll talk you through how it works in our practice. The patient will call, and the front desk will put that into that real-time spreadsheet. And staff from the MAT team will do initial intake on the phone, and also screen for coronavirus, which would affect how we treat the patient if they need to come in. And then the front desk registers the patient. Next slide, please. Then the front desk is involved in scheduling a telehealth visit or a provider appointment. They have the telehealth or in-person appointment with the provider. If they are in person and it's appropriate, we'll do the urine drug screen. If we're not in person, we're not in person, and that's put on hold. And then the patient picks up, if they're a new induction, we generally give them a week from the pharmacy. And then we do multiple check-ins throughout this new induction period. Next slide. Yeah, that's my piece. Thank you all so much. Looking forward to any questions.
Excellent. Laura, thank you so much. And thanks as well to Tanya and Josh for very, very practical and world frontline experience on how to transition to telehealth rapidly and keep our patients engaged. Let me just check, is the sound okay right now? Tanya, can you hear me?
Sounds great right now.
Sounds great right now. All right, so let's quickly move to some questions. Really appreciate the engagement and how many questions we have from our audience. I'm going to start at the top. Maybe Josh, I'll take this back to you. There's a question about going into a little bit more about what some of the challenges have been so far related to the group telehealth.
I think the biggest challenge has been giving patients time to figure it all out. So we've been trying to call them early, letting them know to be available early, and then that way we can help one at a time with each patient if they have issues. We've decided to keep the smaller, more spaced out groups for probably another 2 to 3 weeks, just to help the patients and the staff acclimate to the new changes. And then once we acclimate, I believe we'll be able to get back to business as usual, just everything over telehealth. For example, we had a patient yesterday. We only had a 2-person group, but it took us probably about 30 minutes to get his stuff figured out. And it just ended up, he had it's an issue of, just the kind of the nature of the population we work with. He had a track phone with minutes, not a whole lot of high-speed data. He was trying to use the video and the voice at the same time on Zoom. And so he kept cutting it out repeatedly. But once we figured that out with him, everything should be good to go from here on. So I think the big thing is just being patient.
Thanks, Josh. Next question, and maybe Tanya, you could start on this one. Laura, you might want to add in as well. But maybe too early, but with the clinical changes for patients, are you seeing better, worse, or no difference in retention? Have you given thought to how or if you will revise clinical treatment based on this experience?
So it's a great question, and I think time will tell. I don't have any specific data. I know that anecdotally, the organizations that are doing groups, much like what Josh suggested or was talking about, have seen a bigger uptick in people attending, and people who they know that in person have been quiet at the in-person groups have been quite talkative online, so maybe the comfort level, but in terms of specific retention and et cetera, we don't have that data yet.
Early to tell. Right. Laura, any comments on that? Changes in
Yes. Oh, sorry. Yes, I think we actually have increase in engagement and retention for some of the multiple reasons that people are really looking for something so they don't go into withdrawal and are a little bit more eager or anxious to meet with us and get some support like that. And then the telehealth, again, with the staff going out into the field and looking for people and checking on them, we've had more ability to do telehealth. So I think we will definitely continue a lot of these approaches even past this time.
Right, you're actually anticipating the next question, which from a number of attendees of what do you see happening after COVID? How much are you already thinking or able to think at this point about continuing with some of these new services or changes in service? And if you are, given that we're asking patients to invest in learning these new technologies and practices, do we think that, are we doing it in a way that we are going to help them maintain that over a longer period of time?
Can I take that first?
Sorry, Laura, yes.
Okay. This is something I've thought a lot about, because that period about 3 weeks ago, when so many of the regulations regarding the use of telehealth changed in a day, to me really spoke to how much some of the previous ways we were doing things were just because they've always been done that way. And I was really, really excited to see these restrictions lifted because they were really getting in the way for our patients. And we plan, like I said, to use telehealth much more. If people don't even have, ways to get into the clinic or things like that. And we're very on the fly in our setting. So being able to do a phone call makes it even more on the fly and flexible.
Great. Thank you. Related for right now is a number of questions about how are you engaging patients in behavioral health services who may not have phones or don't have the technology? Maybe Josh, any comments on that?
Yeah, so far we've been lucky enough to where I'd say 98% of our patients have had access to at least a phone. The problem we're probably going to run into soon is the patients who are just using track phones and just have minutes. We may be able to find a workaround with that. We'd already been looking into like contingency management for meth and having one of the rewards be track phone minutes. So that may be something to do. On the other side of it, our admin CEO, he's looking at getting the patients who don't have consistent access tablets. So I'm not sure how far that will go, but that would be awesome. It was his idea, so I'm thinking it probably would go the full way if we needed it. Other than that, we probably have about 3 patients without phones. Luckily, 4, and actually 2 sets of 2, the 2 sets are siblings. So they can help each other out. One of them will have a phone, the other one won't. 2 of them are living with mom, and so mom's the contact info we have. So she's on the HIPAA and the consent, so we can communicate things through her, and they can make sure they're available for the phone, which has been the other big help is finding like a kind of like a person, accountability person. Like there's a patient with alcohol use disorder I've been working with, and mom, it helps with check-ins after she signed HIPAAs and everything.
Okay. Thank you. A lot more we could talk about there. I'm going to see if we can get a couple more questions in. Josh, this one may be a start for you to start as well, but a couple of questions about Zoom and comfort level with sticking with Zoom, or are you sticking with Zoom despite the concerns about hacking and privacy?
Yeah, when I first saw those, I freaked out a bit because I was already halfway through making my protocols. And I was like, well, now I got to do it all. But looking into it, most of the hacking is more people will be able to get the login info and the password and then just jump right in. So we went the route of no passwords just because that adds a barrier and it doesn't seem to protect that much. The one thing we do is we only have one host. We pass it around between whichever providers in the room or whichever staff. And we always implement a waiting room. So that's one of the options in the advanced options on Zoom. You can click have patients go into waiting room. And then that way anybody comes in, you have to admit them. They can't just jump right in. So actually a good example, it was the second Zoom group I did. We had 3 people in the group, and then some random person, I had no idea who they were, jumped into the waiting room, and I just let them be there until it kicked them out. So it actually kind of happened. I have no idea who that person was. Never had a patient by that name, but definitely waiting rooms help a ton.
So using that precaution. Yeah, that's precaution. Tanya, a question for you about, could you share some of the survey feedback questions that you asked patients? Maybe referring back to when you engaged the patient advisory members in helping you develop the telehealth program.
Yeah, so I think it's pretty much the standard survey questions. What worked? What could have made it better? Were your needs met? Did you feel comfortable allowing for open-ended if there's anything they would like to say that maybe isn't covered in a question? And then also just the idea of how to reach others. So, within their community, knowing just how do you reach out to others and what are other ways that we could do this that would be helpful for somebody like we just discussed who doesn't have a phone or is homeless or living in a sober house. So pretty much it's just the basic questions just to see how it can be improved.
Great, thank you. And I love the ideas that all of you have done, I think, in terms of doing those test runs and really engaging that for that patient feedback in that process. Laura, maybe you could lead on this one. Have you thought about doing witness drug screening using mouth swab saliva testing?
So no, because in Philadelphia, the drug supply is very, very much contaminated with all kinds of things. So I guess the reason to do something like that would be to help the person understand what they're really getting, because many samples of ostensibly heroin have veterinary benzodiazepines from Mexico, or cocaine, Tylenol, all kinds of things. So we're steering away from that, except for to have a conversation with the patient about safety.
Okay. Right. Josh, any comments on that?
We've thrown that idea around. That's been recommended by ASAM. The problem we run into, they've recommended like mail out swabs. Is just how to knowing, is it worth it, and knowing that that's actually from the patient. We did like, a Zoom swab, but even then,
Yeah.
it just seems like it's good to have accountability, but with everything else going on, I'd say patient safety first. Almost not totally a harm reduction, but let's just keep everybody safe until this is done.
Okay, thank you. Let's see if we can get one more question in, and relates to the homeless population as well as those transitioning from prison. So how can the addiction community support people transitioning from people to the streets, help them have access to continuation of prescribing, and also induct? The question goes on to say the other issue I see is trying to get the technology for virtual care to this population. Laura, I will comment also, we did our webinar last week, had additional content very much focused on the correctional health and the transition. But Laura, let me turn to you for any thoughts on that.
Yeah, so again, this is where our staff really has worked out these protocols even way before COVID. In Philadelphia, people are generally released between 11 p.m. and 4 a.m. and the staff is willing to go meet them at that time and make sure they have what they need. We can prepare, have a prescription waiting for them and things like that. It's a lot of work, but after we lost some people in the early days, it's well worth it.
Terrific example, terrific suggestion, Laura, of what you're doing there. We may want to look into more, developing more work on how you expand, how we spread that sort of model. Thank you. We are just getting to the top of the hour, to 4 o'clock. So I want to thank Tanya, Josh, and Laura for a really terrific discussion. This focus on the patient experience is very much something that FORE is committed to continuing to develop. It's reflected in the projects that these grantees will all be working on, and we would love to hear from more of you in the audience about how we could continue to develop this work more and help support actions that can make the implementation of telemedicine really work to the maximum potential for our patient populations. Thank you so much. Stay safe and have a good afternoon. We'll see you again soon. Bye.